a consultant ICU and trauma surgeon. He's, I think, in my opinion, he's one of the excellent trauma surgeons I have ever seen recently. And today he's going to present about the shock and hemorrhagic shock. And this is maybe the first of the intensive care series we are supposed to receive in the following days. We are really grateful that he agreed to present this one. تفضل Dr. Shaher.
First of all, it's my pleasure. Thank you for the kind introduction. I hope I deserve it.
Yeah, you deserve it.
Allah يحفظك إن شاء الله. Everybody speaks Arabic. عشان نكون في الصورة ولا في حرار English?
No. Some people are from other African countries and from India.
So English.
And England, yes, English is the best.
Sure. So I want to say hello to Akram Bulbul, who I've seen. He's one of my friends. We worked together in Asir a long time ago. So it's a pleasure to see you. Bismillah ar-Rahman ar-Rahim. So I want to share my screen. Is that possible?
Yes, of course. And one more thing, we used to record the presentations, if you don't mind.
Sure. No
okay,
problem.
Thank you. Thank you very much. Then Mohammed Abbas, you're supposed to record it. Mohammed Abbas is the host from our residence. Okay, thank you.
Sure, my pleasure. So the next question, what are the levels of my audience?
They are all residents, senior residents, actually.
Good.
So,
okay. My favorite.
Yes.
My favorite audience. I'm sorry. Yeah, Bismillah. My laptop is Mac, so it's a kind of tricky صراحة sharing the screen, but I will try to do my best. So share my screen. Okay, Bismillah. Desktop one. Share. Am I sharing?
Yes.
Excellent. So, Bismillah ar-Rahman ar-Rahim. So as Dr. Areem kindly introduced, I'm a trauma acute care surgeon and intensivist. I finished my general surgery 5 years forward in 2015. I did 2 years of ICU fellowship, which is a pure ICU, mixed surgical, medical, transplant, cardiac. And then when I finished the 2 years, I did another 2 years in trauma and an acute care surgery. So trauma and acute care surgery is relatively a new specialty that originated mainly in North American. You know, here in Saudi Arabia, we mainly follow the North American model of medical education and post-grad medical education, and this is actually originated from there. It's not widely adopted across the, so how much time do I have, Kareem?
Actually, it depends on your presentation. So some people do like 1.5 hours, some 2 hours, 3 hours. It depends on your presentation. So it's not a limited time.
And flexible, sure.
Yes, very flexible, yes.
So this is a relative, as I was saying, it is a relatively new specialty, mainly originated in North American. European and Australian and Asian countries don't understand this model, and African as well. They don't understand. I think that they don't accept, as far as my knowledge, South African, they have a mature trauma system there. Other countries and other continents, I don't think they comprehend this new specialty, and I stand corrected if I'm wrong. So trauma surgery and acute care surgery, mainly acute care surgery is a specialty dealing with every emergency in general surgery with more depth and more physiological and anatomical knowledge than I would say the average general surgeon. And trauma, same thing, deals with truncal injuries from neck to mid-thigh. We manage chest injuries, we do sternotomies, we do thoracotomies, we do our own vascular injuries, our own vascular reconstruction. So this is the gist of the trauma and acute care surgery. ICU, you all know ICU. It's have been a trend again in the North American education or postgrad education that trauma surgeons tend to have an ICU degree where they have the knowledge and the skills in managing those highly severely injured patients and severely traumatized patients, or those who have very severe acute care surgical diseases where they need perioperative care and management. So it became a trend that surgeons learn ICU and they can apply that knowledge to our surgical patients. Some are managing only surgical patients, some are managing all ICU. So this is kind of an introduction about the specialty. I'm promoting it because not a lot of surgeons are aware of this new specialty. It's not like our colleagues in hepatobiliary surgeon or colorectal surgeon transplant, where it's been already a well-known specialty since the 90s or even the 80s. We are relatively new and highly demanded in the future, especially I will discuss with the new surgical training. So I'm going to talk about shock, and again, I want to give a brief introduction about what happened in modern critical care and modern medicine that has evolved into having this specialty as trauma and acute care. So as you know, in the 90s, everything have evolved since then. Medicine have been evolving since the early in the 19th century or 18th century. But the major breakthroughs happened over the last 50 years. So as much as we advanced in our specialties as surgeons, same has happened to other specialties: cardiology, medicine, transplant, hepatology. And as a result, more critically ill patients have survived. So a patient in the 80s and the 70s who had an extensive MI would die. Now he wouldn't die because we have thrombolysis, we have urgent PCIs, and we have emergent CABGs. So these patients survives. They survive more, and with those advancements in medicine, those patients will get surgical diseases and surgical pathologies and surgical complications. And we as surgeons have to deal with this. So if we don't know those complex medical situations that lead to surgical diseases, we cannot manage those patients. So a patient who have a liver transplant, a patient who have kidney transplant, lung transplant, heart transplant, they develop acute cholecystitis, they develop bowel ischemia, and as a result, as a surgeon, you get to deal with them. And for that, you need a surgical intensivist to understand the complexity of this medical situation that led to the surgical situation that you are in, and you need their help. Or maybe one of you will choose this specialty in the future and he will help his colleagues, his or her colleagues. So new branches of medicine have existed along with this complexity. We have new branches in medicine. We have perioperative medicine. We used to consult medicine for everything: patient diabetic, hypertensive, hypothyroid, liver cirrhosis, whatever, ascites. We consult our colleagues in medicine. They will optimize the patient for you, and then you go to surgery and according to the risk stratification. Unfortunately, medicine or our colleagues in internal medicine, they're not interested in perioperative medicine. It's the least of their concern. It's the least of their interests to prepare your patient for you. So they're not interested. They're actually, when you consult a cardiologist for a perioperative risk assessment, you most probably, I would say, you would not get the highest rank of cardiology to come and assist the patient for you. They will send the least expert cardiologist they have to answer your consultation because, frankly, they're not interested. They have their own patients, they have their own problems, and you, as a surgeon, and your patients under your name is the least of their concerns. So as a result, we as surgeons, we need to acquire that knowledge and that skills to manage our own patients who have medical comorbidities when we are going into surgery for. That's why you need surgical intensivists. Or at least as a general surgeon, you need to have more knowledge into the perioperative complications for your surgical patients. As well as perioperative medicine, we have palliative. Nowadays, we have pulmonary embolism teams. In the old days, I remember when I was a resident as well, it wasn't long ago, it was 2011, 2012. When a patient developed massive PE, he dies. That's it. Now, we have so many options. We have catheter-directed thrombolysis for high-risk patients. We have, when in advanced hospital, they have cardiac surgeons on guard, on board. They can do bypass for those patients. We have ECMO for massive pulmonary embolism who are arresting. We have so many options that evolved that can manage pulmonary embolism. Same thing with sepsis, and we have sepsis codes and sepsis team, and as well as stroke codes. So things are evolved. We have now teams that manage a single condition, while in the old days used to be one physician. Now we have teams, and you have to have a multidisciplinary care, more than one physician, where you as a surgeon, as the leader of this team, has to organize the efforts of all those teams in favor of your patient. For example, I have a patient now who had a gunshot thoracoabdominal on the right side. He was operated somewhere else, and he came to me and he arrested. And I did for him left thoracoabdominal, anterior thoracotomy, and I did for him a laparotomy as well. And luckily he survived with the full conscious GCS 15 or 15. Now he's on the ward after spending 2 months in the ICU with all the complications you can think of: VAP, pneumonia, wound infection, DVTs, all the complications you can think of, he developed it. Acute kidney injury, dialysis, open abdomen, all that he developed. And now he's a conscious, oriented, asking about his family in the ward. What to do with this patient? He's severely cachectic, he's severely myopathic, he's tracheostomized, his NGT tube feeding, he cannot swallow. So we have to reconstruct that human being from ground zero back to a functional person. I need a dietitian on board. I need a physical therapist on board. I need to do swallowing assessment for him. I need to win his trach. I need to work on his stoma. He has an ileostomy, which is high output. I need to work that out. I need to work out his antibiotics. All these needs good leadership, knowledgeable leadership that can organize all that teams into one single team. Nowadays, medical care have evolved into more complex provider. So it's not just that you do an open appendectomy and you get a wound infection, you leave the wound open and the patient stays for 10 days and antibiotics and patient survives and he goes well and that's fine. No, 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 no. Modern care is less hospital stay, less cost, less infection, less morbidity. So it's not enough. It used to be enough in the 90s to do an open appendectomy or a hernia. Patient gets an infection, superficial infection. So what? Give him antibiotics, you do a dressing, you leave the wound open, and most probably he will make it. Nowadays, no, it's not okay. Your pay as a surgeon depends on your complication rate. The length of stay of your patient in the hospital is counted on you. The wound infection rates is counted on you. The amount of antibiotics you prescribe is being supervised by antibiotic stewardship program by the ID colleagues and the clinical pharmacist. And you cannot just prescribe antibiotics for 20 days, 25 days, and just that's okay. No, it's not okay. So quality of care has increased. And you as a surgeon, it's not enough just to do a surgery and you get a minor complication and you get away with it. No, it's not okay anymore. It was okay in the past. Now it's not. I don't think I'm gonna go through with more introduction. I think I gave enough introduction about the trauma and acute care and critical care. I'll skip it for the sake of time. since most of these slides are made for my residents in my hospital, so it was mainly directed to the Saudi or Saudi board residents, and some of it are relevant to the training of here in my country. I just want to say that one more thing in the introduction, that the training of general surgery, I don't know about what's happening in Sudan and other countries, but here in Saudis, as a reflection of the North American, and I'm not sure I agree with that, but this is the situation, this is the reality, and we have to deal with it. There is no more general surgery training. In the big hospitals and the big centers, you don't have general surgery training anymore. You have subdivisions. You have hepatobiliary, you have upper GI and bariatric, you have colorectal, you have acute care and trauma surgery, and you have endocrine surgery. And these are the specialties where surgeons or general surgery residents rotate among these specialties. They're not anymore general surgeon. And most of their training will be scrubbing into Whipples, scrubbing into transplants, scrubbing into total colectomies. And due to the complexities of the operation, the surgical exposure and the surgical skills will not be as good as those who get trained into general surgery, pure general surgery without advanced subspecialty training. As a result, the need for trauma and acute care arises because of those complex medical comorbidities I've mentioned before, and because the training in acute and general, pure hardcore general surgery have decreased. And that's why we need trauma and acute care surgery as a specialty. I'm going to skip it for the sake of time, and I'm going to go into our topic today, which is shock. So as you all know, the reason behind all causes of shock is, can we make this more interactive? Is that possible? So what do you think is the reason behind all causes of shock? What happens in shock? What is the underlying etiology at the cellular level? Anybody, please, go ahead.
Inadequate tissue perfusion.
Yeah, so it's the blood not reaching to the tissues. That is correct. So what does the blood carry? It carries oxygen. So it's not the perfusion itself, it's actually the oxygen within the blood, namely within the hemoglobin, that does not reach to the cell. And as a result, the cell has to have another mode of energy supply to go on into its cellular functions. So actually, it's the definition that we all know is inadequate tissue perfusion. A lot of intensivists would not agree with this definition because it's not very accurate, but I would go with it. I think it's very simple. Everybody knows it, and I would go with it, and I agree with it. The reason why they don't agree, because at some level, there will not be an adequate tissue perfusion, and the patient will not be shocked because the cells will depend on anaerobic respiration, and it will get its own energy from within without the use of oxygen, without the use of Krebs cycle. And the byproduct will be lactate, and that's why they will have lactic acidosis. And at that period, there is no proper tissue perfusion, but at the same time, it's not shock yet, although it's a pre-shock state. If the patient resumes his perforation, or if the cardiovascular system resumes perforation, the patient will not be shocked. So that is the problem with this definition, although it is globally correct. So let's see. So this is the oxygen molecule. I'm having a problem because I have this in front of me and I cannot get it out. Just allow me for just 10 seconds to take this away. Okay. So this is the oxygen molecule. It comes from air, comes from the atmosphere. It goes to the lung, the factory, where it gets transferred from the atmosphere to the lungs, to the alveoli, to the membrane between the alveoli and the blood capillaries, and then to the hemoglobin. Then, obviously, to the heart, to the pump, where the pump takes that blood or oxygenated blood through the pipes, which is the arteries, to the cell, which is the end user, where the oxygen gets consumed through the Krebs cycle, then through the blood, mainly the venous blood, which what we call the reservoir. The venous blood take it through the veins, going back to the lungs and out the CO2. So this is schematic showing the natural process of oxygenation and tissue perfusion. And you can see we have more than one component where any breakage in this link or this cycle, you will have shock. And let's go with it. If we hypovolemic shock, we can describe the shock and to classify the shock into 4 categories, as you all know, most commonly the 4 categories, although we can make it into 5, and we'll see later how. Hypovolemia, when you have a patient, hypovolemic shock can be either hemorrhagic shock, either the patient is bleeding, or it can be due to what? Can somebody tell me what's the other possibility of hypovolemic shock other than hemorrhage?
Dehydration. Dehydrated.
Excellent. So dehydration, so you mean loss, GI losses,
Loss.
vomit,
Excessive sweating, for example.
Excellent. And all that. Excellent. What else? So either bleeding or GI losses or any hollow organ losses. What else? A very important one. What happens? So, sorry? Burns. Somebody said burns. Why? What happens in burns?
So there's 10 spacing of fluids, which is not physiologically available.
Excellent, excellent. So third spacing. So the way you can have hypovolemia, either you have a blood loss, a fluid losses, whatever those fluids are from, either sweat, GI, vomit, urines, heat stroke, whatever, or third spacing. The fluid are not lost outside the body. They are still inside, but they're not within the venous reservoir. They are in the tissues. They are in the interstitium. They're not working. They're not taking the venous blood. They're not taking the CO2 from the tissues back to the lungs. They're not active in their job. They are just on the side. They are extravasated outside the vascular tissues, vascular beds, into the interstitium. And they are not contributing. That's the word I'm looking for. They're not contributing to the perfusion process. So the other thing is obstructive shock. So we don't have any loss. We have enough blood. We have the tissues. We have the pump. We have the tissues are perfused, but the blood is not going back to the lungs or to the heart. There is an obstruction. That's why we call it obstructive shock. Can you give me examples, please?
Pulmonary embolism.
Excellent. What else?
Abdominal compartment syndrome.
Excellent. What else?
Tension pneumothorax.
Excellent. What else? Anyone?
Cardiac tamponade.
Tamponade. Excellent. So these are the classic 4. These are the classic 4 for obstructive shock. Tension, pneumothorax, tamponade, abdominal compartment, and massive PE. That is.
What about aortic dissection?
It's not, and we'll discuss it later, because it's not obstructing the venous, and aortic dissection does not obstruct the flow. And we'll see why later. That's a good question. If I don't mention it, just remind me later. Aortic dissection, usually they're not shocked. Usually they're not shocked. And the patient, if your patient has aortic dissection and he's in shock, it's not due to the dissection, it's something else. Dissection, if it's traumatic, that is different from a spontaneous dissection. Spontaneous dissection happens because of severe hypertension to the extent that the wall gets dissected and you have a false lumen. And for trauma, they get severe injury to the aorta where the aortic wall gets shear injury and you have a false lumen. And the patient, if he doesn't have any other injury, they will not be hypotensive. They will not be shocked. So it's actually aortic dissection does not cause shock. And and actually we give them beta blockers and we give them antihypertensive medication to control the blood pressure and to control their heart rate. So I hope this answered the aortic dissection question. So next, there is the cardiogenic shock. So as surgeons, we rarely see this as a cause of shock in our patients. It's very rarely. I've never seen a patient under the general surgeons who cause a cardiogenic shock, unless very advanced disease where you have an MI, a massive MI, but that is usually, I don't think you can do much about it. But this is usually in the intensive care where you have acute coronary syndrome and post-CABG and post-bypass where they have cardioplegia, and usually you don't have to deal with this as a surgeon. So I will skip it. It's just simply, it's a failure of the cardiac pump to pump blood out. It can be either diastolic failure, poor filling, or systolic failure, poor ejection. I will skip it for the sake of time, and I don't think that you need it as a surgeon. And now we come to the big one, which is the distributive shock. And this is what you see almost always. What happens in distributive shock, guys? Can somebody tell me, please? And can you give me examples of distributive shock, please?
So in distributive shock, we have massive vasodilatation.
Excellent. This is vasodilatation. And sepsis. And we said the most common example of distributive shock is sepsis, where you have an infection and that infection have caused systemic inflammatory response syndrome, where you
Dr.
have
please share
a cytokine release. Oh, sorry.
Can you share the screen? It's not shared
Sure.
at the moment.
Should be now.
Yes.
So, So I was talking about distributive shock, and I said that the most common example is a sepsis, where you have a systemic inflammatory response, and you have that disturbance in the vascular tone of the capillaries and the muscular arteries where they get vasodilated, and you lose your diastolic pressure initially and then your systolic pressure later on. Another example of distributive shock, can somebody tell me, please? Other than sepsis.
Anaphylactic shock.
Anaphylactic shock.
Excellent, excellent. Anaphylactic shock. So what happens in anaphylactic shock is the same. You have a trigger, mast cell release, extends histamine release from the mast cell, and it causes the same problem. You have a severe vasoplegia and loss of vasomotor tone. You have second drop of blood pressure. What else?
Neurogenic shock.
Excellent, excellent. So neurogenic shock, what happens in neurogenic shock? How happens? Same thing. So at what level of spinal cord injury does neurogenic shock happens? Is there a level? Does it depend on the level or it doesn't? If you get a spinal trisection or a severe spinal injury at the level of L2, will neurogenic shock happen in this level of injury? No. It needs to be very high. There is no specific exact number, but it should be T6 and above. T4, T6 and above, where you might have, because when it's more high, when the injury is higher, the more sympathetic nerves gets affected and gets paralyzed. And as a result, you will get vasomotor tone dilatation and lost. And then you will have the hypotension, the neurogenic shock. If the spinal cord injury is lower, then you still have enough sympathetic supply, nervous supply above that can compensate for the loss below. And then you can maintain your vasomotor tone. Plus, the heart, the sympathetic supply to the heart originates from the same level, T3, T4, and the sympathetic supply to the heart, if it gets affected, the heart will get bradycardia because sympathetic supply elevates heart rate, and if then that gets affected, it will drop and you get a bradycardia, and as a result, you'll get hypotension. The parasympathetic supply to the heart is through the vagus system, the vagus nerve, which is a cranial nerve, and it comes directly from the brain, and it doesn't get affected by injury in the spine. I hope that's clear. The fifth cause of dissociative shock, or the fifth class of shock, is dissociative shock, and it's not common. You don't see it a lot in the books. You don't see it. You don't see a lot of surgeons or surgeons, physiologists mention this dissociative shock because it's very rare. And the cause of dissociative shock is when you have everything is in check, everything is working very well. You have enough blood supply. You have good venous system. You have the lungs working well. Are okay. But the oxygen reaching to the cells, but the cells are not consuming that oxygen. The problem is within the cell. That's what we call cytotoxic shock or cytopathic shock. The problem is within the cell. This happens in rare cases. And can somebody mention any examples? So I knew that it's kind of rare. It's cyanide poisoning, but you have poor uptake of oxygen. The cyanide gets hooked to the mitochondria, and it causes inability of the cells to take up the oxygen and use it. So you have everything in check, but the problem is the cells cannot uptake. Some examples also, carbon monoxide. Although carbon monoxide affects the absorption of the hemoglobin to the oxygen. So it's a carrier kind of toxicity and shock, but it's more or less the same. And I will not go into details with that. So why septic shock is a big deal? Why we talk always about septic shock and it's a priority, and we have campaigns and we have guidelines for septic shock? Because septic shock can affect almost 4 of these. Septic shock can cause hypovolemic by third space, because septic shock causes distributive shock as well. Septic shock causes vasodilation, and it will increase the permeability of the capillaries. So the volume will extravasate into the interstitium. So instead, in addition to the distributive shock, it causes hypovolemic shock. And on top of that, some forms of septic shock and some forms of viruses and bacteria and fungi causes cardiogenic shock. It impairs the cardiac contractility. And on top of that, on advanced stages of septic shock, you have a dissociative shock, where you have a poor uptake of the cells to the oxygen. So that's why septic shock is very lethal and have a high mortality rate, because it can cause shock through so many mechanisms. And that's why septic shock is such a lethal disease, and it's such a big thing in the medical literature. If we approach these causes of shock, and this slide is like the summary of all my presentation, and I'm focusing on this a lot because it's the gist of everything. If you understand this, you understand shock. So if we take it from an ABC, because we as a surgeon, we like the ATLS and we like the ABC approach because it makes things simple. And I like it as well. When I teach shock, I like to go through the ABCs. And when you teach medical students, everything we say, when your patient is sick, you say ABCs. We just memorize those. So if you go through ABCs, you can see the A, which is the airway that takes oxygen from the atmosphere to the lungs. If this gets obstructed, then that's a problem. And this is the first stage of A, the first stage of shock. The patients have an obstructed airway, or the patient is asphyxiated, or the patient has drowned, or the patient went into very high altitudes like the Alps or the Himalayas. They get so low partial oxygen pressure, they cannot breathe. So that is a problem. Number 2 is B, B is breathing. You have the oxygen coming from the atmosphere, it goes through your airway, and it goes through your lungs, bronchi, and it goes to the lungs. But the problem is, it does not get transmitted to the blood. The blood does not get oxygenated by the atmospheric oxygen. So that's a B failure. That's a breathing problem, like a tension pneumo, like a hemo, like a pneumonia, like aspiration, like collapse. All these problems are in the B. C can be either the heart, can be either the volume, or it can be also obstructive, the venous supply. So, So the C can be a failure in the heart. Patient has very low cardiac reserve. It can be in the volume, as I said, or it can be, that the blood is not reaching to the lungs in the form of obstructive shock, like, as we said, tension pneumo or tamponade. So C can be so many things, and that's why C needs more than just a simple effort to exclude it. So C is serious, and I hope this makes it clear. And if you have any question before we move on, because this is very important and this summarizes the whole thing. Any questions so far? Okay, then I'll move on. Any questions?
Yes, please.
Okay.
If anybody have question, just unmute yourself and ask. Otherwise, you can put it in the chat. I will follow it.
Yeah, no problem. So I know that our presentation is mainly shock and hemorrhagic shock, and we'll speak about hemorrhage. And I can tell you from now, there isn't much thing to say about hemorrhagic shock, except that stop the hemorrhage. So we'll discuss it later. It's just that I'm focusing on septic shock because it's very hugely more important than hemorrhagic shock, because more patients will die from septic shock rather than from hemorrhagic shock. And there is a knowledge gap, a big knowledge gap in septic shock as compared to hemorrhagic shock. That's why I'm focusing on that. This is the Surviving Sepsis campaign, established again from the States, where they have made the so-called 1 hour bundle. And this is 5 things you need to do once you suspect a septic shock. Septic shock means patient who is suspected to have infection and he is hypotensive. And all this has to be done within 1 hour. So this is very, very, very important, to the extent that major hospitals and major centers have made teams, dedicated teams. They call it sepsis team, or whatever they call it. It has different names, different hospital, just to make sure that these 5 steps or 5 things to be done within 1 hour. And if you want to know whether your hospital is good, it's one of what's so-called the KPIs, the key performance indicators. Whether your ER or ICU is doing very well, is that you measure whether all these have been done within 1 hour or not. And actually, one of the studies have been suggesting to be done within 30 hours. So number 1, measure a lactate level. I understand some of the hospitals don't have a lactate, so that's very unfortunate, because it's such a good indicator of sepsis and poor perfusion. As I said, because the tissues go into anaerobic respiration, and the byproduct of that is lactate, and you can measure that through the blood gas machines, and it's very cheap, and it can be done within minutes. And I would encourage you to ask your administration to bring it to you, lactate through your ABG machine. And number 2, obtain blood cultures before giving antibiotics. And if you think that will take time, give the antibiotic anyways. Number 3, administer broad spectrum antibiotics. And this is the most important thing, and this is what have been proven to decrease mortality, giving antibiotics within the first 30 minutes or the first 1 hour. And this is a major problem in my hospital, and I've raised it to the administration more than one time. We have such a delay. We have a huge delay of giving antibiotics to septic patients. Patient comes to the ER with a diabetic septic foot, then there is a problem between ER and he will refer to general surgery. General surgery are not happy because they think it's vascular surgery. Vascular surgery will come after 3-4 hours, and they will assess, and he will call his senior, and his senior will reply after 2 hours, and then he will say, no, it's not for us, call ortho. Ortho will come, say we have nothing to do, and it will go back to the general surgeon, and then it's 2 a.m. in the morning. He doesn't want to disturb his consultant. He will keep the patient till morning, and then the consultant will come after 24 hours, and then the patient will admit it, and they will give him antibiotics. And you will see why is this a huge problem. Number 4.
That's so true. It's the classical scenario. And one more thing, if you manage to get the patient soon, then you will have to fight with the ID. And you know that.
Yeah, exactly. And that's why we've discussed it with the ID that the first dose, the first 24-hour dose is our privilege.
Domain,
And
yes.
Yeah, they agreed on that because they understand the importance of this. And then giving fluids, as you all know, in hypotensive patients, it should be 1 liter to 1.5. And if not responding, you should call an intensivist to put a central line and start inotropic support. Should not give 3, 4, 5 liters. This have increased mortality and it does not work. You should apply vasopressors early if the patient does not respond to resuscitation early. So this is the bundles. They made it into a card where you can just hang it with your ID and just to remember it. And it's very important. It's a very big deal. And I encourage all of you just to Google Surviving Sepsis campaign and read all about it. And there is a free presentation, and I will leave. This is a 1 hour presentation. Obviously, I'm not gonna stream it all, but I'm gonna present the first 6 minutes. I'm taking too much time, but this is very important. This is worth it. This is Philip Dellinger. He's the lead professor, and he's the one behind the Surviving Sepsis campaign, and he's in the leadership position in the States. This is in collaboration with the European Society of Critical Care, and he will talk about the bundles. Bear with me, it's just 6 minutes, and it's very important.
This is Phil Dellinger talking to you today from Cooper Medical School of Rowan University and Cooper University Hospital in Camden, New Jersey. Going to be talking about the Surviving Sepsis Campaign Hour 1 bundle. I held a leadership role with the Surviving Sepsis Campaign from 2002 through 2016. I think I have a unique perspective to talk about the Hour 1 bundle, which has been met with some controversy. And I really don't think it's controversial. I think it's just misunderstood by some people, and I hope to rectify that. Let's begin by talking about the burden of sepsis, and I'll give my perspective, since I'm from the United States, of the burden in the US. Hospital mortality for sepsis and septic shock, very high, 14.9% and 34.2% respectively, well over 250,000 deaths per year. It's the single most expensive condition treated in hospitals and makes up 13% of hospital costs. Machiavelli is noted for the insightful comment, hectic fever at its inception is difficult to recognize, but easy to treat. Left untended, it becomes easy.
Let's skip that for the sake of time.
2016 Surviving Sepsis Campaign guidelines have a best practice statement that states sepsis and septic shock are medical emergencies, and that treatment and resuscitation should be begun immediately. The Surviving Sepsis Campaign 3-hour sepsis bundle from 2015 has 4 metrics to be completed within 3 hours.
So it used to be 3 hours bundle and 6 hours bundle, and they changed it into 1 hour bundle. I will skip it. So I won't go into, this is the most updated is 1 hour bundle. I will skip it so it won't confuse you.
Sure. Initial lactate. And you'll also note on this slide that although the 3-hour bundle identifies antibiotics as being administered during that 3-hour period after presentation, large.
This is actually why I showed this. I took this presentation and I showed it in, and I will skip it. I will just summarize it for the sake of time. This graph shows on the bottom the time from hypotension, the time where the patient presented to the ER, or the time from the patient we were hypotension, and when the patient have received antibiotics. So if the patient received the antibiotics within, as you can see, within the first hour, this is the survival rate, 80% survival rate or more. Let's compare it if the patient received it from within the 4th hour. The survival rate decreases to less than or about 60% or less. Let's compare it if the patient received it within 9 hours. So what happens? The survival rate decreases to 30%, meaning the mortality will increase to 70%. So this is a very famous article, which is by Kumar, and it's very, very famous. And this graph, you will never attend any septic shock presentation without they putting this graph on. And the reason I brought this because of this. So starting antibiotics early is so important to the survival of your patient. I cannot stress this any further. I will go to more case scenarios now. Enough talk. Let's talk cases, because this is very important, and I think solidifying that knowledge into real cases, it will make, inshallah, stick more. So these are real. The pictures are not real. I took it from the internet, but the cases are real. So I need a volunteer. Dr. Reem, just appoint someone, if somebody not going to volunteer.
Okay.
So this is a 70-year-old male, diabetic hypertensive, he's an ischemic heart disease, chronic kidney disease, hypothyroidism. He was referred from the ER as a diabetic septic foot. Patient looks ill, blood pressure 98/45 with a heart rate over 82, heart rate of 82. What would you do? History and physical examination, we all know that, but I need more specifics regarding to that patient. So what do you know? What do you need to know about the history? And what do you know to examine? Focused history, focused examination. Someone volunteer, please.
Any volunteer? I think Dr. Muhammad Abbas is going to reply now.
Yalla, bismillah.
Yalla, Muhammad.
Focused history, focused examination. Go ahead, Ashan, so I will not take too much time.
Yalla, Muhammad Abbas. Come on.
Come on, guys. Just history. Okay. I will talk, and because I have 2 more cases, and I need to. I think it took too much time. So in the history, I want to know what kind of management. If his blood sugar is not controlled, I definitely need to control that ASAP as for his wounds. Management. This is what's this lecture about. Hyper control or not? What kind of medication? On blood thinners, meaning anticoagulation, aspirin, warfarin, Plavix, rivaroxaban, apixaban. Now we have a bunch of new stuff that we really need to know a lot about anticoagulation, not like before. The other day I had a patient who was 95-year-old, atrial fibrillation, who was on rivaroxaban. So if you don't, and his INR is normal, his PT is normal, his PTT is normal. And the registrar was telling me, he's fine, we can operate on him. He doesn't know that the rivaroxaban does not get monitored by the regular coagulation profile measures. The patient will have INR, normal PT, normal PTT, but the patient will be coagulopathic. And if you operate on him, he will bleed like hell. So you have to understand, if you don't know that, and then you will risk operating a patient and he will bleed to death. Because rivaroxaban, if you want to reverse rivaroxaban, you will need very, 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 very expensive medication, which is most probably will not be available. Prothrombin complex, which is even in my hospital is not available. In my country here in Saudi, it's available in 2 major hospitals. So it's not, you have to know what your patient is on. So chronic kidney disease, what's his creatinine level? What's his basic level? What's his baseline creatinine? Is he following the nephrology or not? Hypothyroidism, what dose is he on? Is he medication? Is he doing regular follow-up with an endocrinologist? Is he doing TSH? When was the last TSH? How much is dose? So these kind of history information, you really need it. Otherwise, you will not achieve the best results you are hoping for, and your patients as well hopes for. So that's in the history part. That is obvious. Now, if you ask me, how did the patient get his injury? Did he fall? Did he have an injury, they have foreign bodies, yeah, that's important. I understand, I agree with that. But will it change your management? I don't think so. So physical examination, you all know that. I hope that you know that. Blood supply, you will check the blood supply because this is very important. You will do Doppler, handheld Doppler, and if needed, you will do CT angio. You will check the pulses manually, of course, beforehand. You will do the brachial, the ankle brachial index. You will examine the whip spaces. You will do X-ray. You will see the calcification within the vessels. You will see if there is any foreign bodies. You will see the osteomyelitis signs on X-ray. And if you need MRI, you would ask for it. All that kind of stuff. That is not our concern at this moment. We're focusing on the shock part. So patient history, and we took the old file as well because the patient was not giving much of a history. So to bring the old file. So as I said, he's taking all the diabetic hypothyroid medication, and some were outdated in the file, and we actually asked his son at home. They didn't bring it, so they took photos and they would send it to the WhatsApp because we have technology nowadays, and we actually saw the medications. And I'm so happy that I saw it because the patient was on Plavix, aspirin Plavix. And the patient was very poor diabetic control as we suspected. And we started him on aggressive insulin infusion. And you shouldn't, you know how, definitely you would need to ask a good, just a simple sliding scale, not solve your so uncontrolled hyperglycemic. The last cardiac status is last cath, whether the patient has that stent or not, whether the patient has balloon or not. Had stent, and he had the stent 6 months ago before presentation to the before us. And when we inquire, patient had a drug-eluting stent, and the patient had drug-eluting stent. You cannot stop any anticoagulation of this patient, because if you stop aspirin and if you stop Plavix, there will be very, very, very high thrombosis, and the patient will have an MI, and most probably the patient will die from his heart rather than from his foot. So you need a cardiologist on board. We actually operated on the patient while he's on aspirin and while he's on Plavix. We did not stop them. We took the rate of bleeding, and thankfully we were successful with that. Vascular, he had good pulse with a good triphasic signal, so we did not need any vascular input, and that is what happened. Clinically, what do you think is the patient? So that is the history part. So clinically, do you think the patient is in shock or in occult shock, and how would you assist that patient? So this is our topic today. Let's go back to his vitals. So this is his vitals. Do you think this patient is in shock or not? And if yes, why? And if no, why? Come on, guys, we need some interaction. Otherwise,
Hello?
Go ahead, please.
Yeah, so looking at the blood pressure, the BP is 98/45, which is low. Heart rate, not tachycardic, but looks rather like borderline bradycardia, not so profound. And from his clinical history with his comorbidities, and looking at the image, that shows a foot ulcer. So you can conclude that he's in septic shock.
Why would you say that he's in septic shock? Why?
So the blood pressure.
Why? What's your target? What's your target? Less than 100, less than 90?
No, it should be less than 90.
He's not less than 90, he's 98.
Okay. His map.
Don't give up.
Hello?
Don't give up. It's not
no,
that simple.
No, I haven't given up. The blood pressure is 98/45.
So?
The systolic blood pressure is 98. The diastolic is low, 45.
Yes, thank you. So the diastolic is very low. And so what does that signify? This signifies an early septic shock, because still the vasodilatory shock, his arterioles and his capillaries dilated. He's still in the early phase. If you wait on him, if we don't resuscitate him now, he would definitely get worse and worse. Why is his heart rate? What do you think of his heart rate?
So he's still trying to compensate. That's from the heart.
If he's compensating, he should be 120, 130. That's not compensation. That's failure to compensate.
Just look at the medication, please. Check the medication. A small hint for you.
So he's diabetic, he's hypertensive. It's possible that his medication could be one of the causes of his decreased blood pressure and heart rate.
Excellent. What kind?
His antihypertensive.
Exactly, that's true. So hypertension and beta blockers, all ischemic. Exactly. So all ischemic heart disease patients with systolic failure or congestive heart or heart failure in general should be in beta blockers because it improves mortality. It decreases mortality, improves survival. So all patients who has ischemic heart disease should be on beta blockers. So this patient, he's on beta blockers. So you don't expect him to have a compensatory tachycardia. So plus this patient is a hypertensive patient. So you would, if he's controlled, hopefully, then you would expect his blood pressures to be in systolic 130, 135. If he's controlled, if he's not controlled, then his heart rate his blood pressure should be in 140, 150, 160. And this is severely hypotensive state for the patient. Plus, numbers alone is not enough. So the perfect answer, if someone asks you, is this patient in shock or not, it's not just the number. We never rely on the number. My brother he's an athlete, and his heart rate, his blood pressure never exceeds 92. And he's fully conscious, oriented, is fine. He's very good athlete and he's older than me. And this is his normal blood pressure because his heart is fine. He has a good heart, he has good vessels. So heart rate also baseline, usually some people in athlete in good health state should be in the 60s and the 50s. And some, when they sleep, it reaches 40s. So numbers alone is not enough. You need the whole picture. You talk to the patient. You assess his level of consciousness, which is the best assessment for shock state. If the patient is drowsy, if he's irritated, if he's agitated, if he's easily agitated, then this is an early sign of shock. You assess his mucous membranes. You see if he's dry or not. This is very important. We teach in med school, but nobody's doing this anymore when they get to the postgrad level. Unfortunately, I do that, and I always do that. I always assess their mucous membrane. I always assess their skin. I always assess their armpits, whether it's dry or not. I always assess their level of consciousness. I always do blood gas for these patients to assess if they have lactate, if they're acidotic, if their base excess is getting higher, if their bicarb is getting lower, if they're acidotic. Urine output is good, and I know everybody will say urine output. Unfortunately, urine output is not good in the first 2-3 hours because you don't know. You'll put the Foley's. The patient already has urine in his blood, and he will give you 200, 300 initially, but you don't know how long it's been there. And the urine output is not good initially, but it's very important on the progression of the disease. Lastly, capillary refill. Capillary refill is very important, and I cannot stress this any further. And please, you need to do this. It's very important. So this is part of the physical exam. Actually, exactly had the delayed. He was but he is shocked. All the criteria for shock. So what would you do? What would you do in this patient if you have this patient ER? Remember the bundles. What would you do? Just someone remind us about the bundles, please. What are the 5 steps? Oh, shit. Okay.
Check the lactate.
Lactate, excellent.
Then the second one, you take blood samples for cultures before you start your antibiotics, broad spectrum antibiotics.
Excellent.
Then you also do your fluid challenge by giving crystallized at 30 ml per hour, and if the lactate is about 4.
Excellent. 30 ml per kg per hour.
Yeah. Then you start your inotropes, your inotropes, your vasopressors. If
the patient is not
responding to the fluid therapy, that's the 5th one.
Thank you so much. Excellent. Thank you for your contribution. Starting on clinical supervision, which is the preferred diabetic feet. Positive, great gram negative. Please try to avoid other antibiotics. These are the best in these kind of cases. You examine the web spaces. If there is any suspicion of fungal infection, you will start them on fluconazole. Sometimes it's fungal and it will not respond to antibiotics. You might start them, and if they don't respond to fungal, it's needed amputation anyways, and he made a great recovery. We did an amputation. We put a drain, and it came bringing the drain because he was on Plavix, and we did extensive hemostasis, and luckily. So please don't forget the cultures. If you can take cultures during the amputation, tissue cultures, please. If your hospital can give you a reading about tissue culture, it will be great. Don't throw. If you see any pus, please send it for culture. It will help you a lot. And starting on broad spectrum antibiotics. Labs, lactate, blood culture as well. Radiology, don't forget to see the X-ray, and microbiology if the patient had previous cultures or send new ones for him. So these are, I've already talked about this. I told you already. So we've discussed all this. So this is the management, antibiotics early within the first hours. Actually, this is a very important point. The fact that you write the antibiotics in the file does not mean that the patient will receive it immediately. So writing in the file or telling the nurse, please start him on antibiotics, does not guarantee, and it's not enough. It does not guarantee the antibiotics will be given. So you have to make sure that the patient receives the antibiotics rather than just writing it in the file. So we'll talk all about this, and discussion. So one of the important things that in septic shock, before we move on to another type of shock, which is dopamine renal dose. It's a very common practice that intensivists or some physicians give dopamine low dose, we call it renal dose, just to increase the blood supply to the kidneys. That is proven by evidence it is useless, and it has no use at all. So I know some senior intensive would you start your please don't, it's useless. The steroids, when you get steroids in septic shock, there are so many trials since the 80s about steroids and septic shock. The summary, and I'll give you the summary from the latest trends, and we have as in our country and the National Guard in Riyadh have, which is international multicentric trial, and the conclusion: steroids you should give only when the patient on maximum in a report and he's not responding. So the patient noradrenaline and vasopressin, still the patient is not responding. So now it's the time to start steroids. Before that, patient low dose inotropic support, or he's not inotropic support, there is no need for steroids. Activated protein C, it used to be in the past, not anymore. Swangans, not anymore. Colloids, starch, not anymore. It's actually increased mortality. Strict blood sugar control, the trial Nice Sugar, the randomized trial of Nice Sugar, said that you don't need to aggressively control blood sugar to 120s, actually advised to 180 to 140. So you cannot it's not advisable to control blood sugar to very low levels, to 100 and 120. It's actually better to leave it up to 180 or to 140. So that's it for septic shock. Any questions? I still have 2 more cases. And if I took too much time, I apologize. And if you are tired, I can stop. And please tell me, where am I? Am I live or?
Yes. I think you have 2 more cases, yes?
Yes, 2 more.
Just proceed with them.
Right. So the other case, so this is an interesting case. This is a trauma, 32. This is, I had it when I was doing my trauma fellowship. It's very interesting. The patient, not for the patient, 32-year-old male, trauma, road traffic accident. He was a rollover case. He had a decreased level of consciousness. He was immediately intubated by the ER consultant and the ER staff, and he was hemodynamically stable. So when the patient was stable, they took him to the CT scan. We do pan CT for trauma patient. When we have severely injured patients, we do pan CT, meaning brain, neck, chest, abdomen, pelvis. And it was all normal. Then he was shifted back from the radiology to the ER resuscitation room. And then 30 minutes later, the patient started to drop his blood pressure from a normal previously 135/72. What would you do? They called me at this moment and I came and I assist the patient. What would you do at this situation? Please volunteer quickly, please, because I don't have the luxury of time.
So you would like to find out from the history or your examination whether there's any focal neurology, a neurological fallout?
They said he was level GCS was low and did not get the chance to evaluate him. But that's a very good question. Why you want to know that? What are you thinking about?
That one will help you to exclude any neurological shock.
Excellent. So first thing, you're thinking about neurogenic shock. What do you want to ask me to know to make you certain that this is neurogenic shock or not? One question.
Does he have a cervical collar on?
Oh, yeah. It's a routine. It's a routine of pre-hospital to put all patients on collar. But remember, we did a CT scan for him and it was normal. So if there is a spinal cord injury or a spinal fracture, it will appear. But you are right, the radiologist might be mistaken. And what do you want to know to make sure whether this is neurogenic shock or not? One question.
Pulse rate.
Heart rate, excellent. So if the patient is bradycardic, then this is sure, yeah, he's hypotensive for sure, because he was 135/72, and now he's 90/40. So we are sure that he's hypotensive. We are definitely sure. So neurogenic shock, we can exclude it with 2 things. We review the CT scan and with the heart rate. If the heart rate is high, 110, 120, then it's not neurogenic shock. If it's low, and despite the normal CT scan, the patient might have a contusion, spinal cord contusion, and that will not appear in CT scan, it will only appear on MRI, and still the possibility of neurogenic shock is there. So the heart rate is the main determinant. What else? Okay, so I will tell you, his heart rate was 120, and his CT scan was normal, and he was wearing a collar, and there is no abnormalities in the CT scan. What are you thinking about? What else? This is not, I like this case because it's an approach case. It makes you think systematically how you approach hypotension.
And does he have a chest X-ray?
Okay, you think it will help? He did a CT scan. This is a tricky case. I brought it because it's confusing. It makes you think differently. I could easily bring you a fresh trauma case, and you will all tell me all about the ATLS, which I'm sure you all know about. I don't want to that. I want to challenge your minds with a different case. So would you want to do a chest X-ray or not?
Yeah, so just to rule out attention pneumothorax.
I can tell you for sure that the sensitivity of the CT scan is 100%, 99 to 100%, while the sensitivity of chest X-ray is 60% for pneumothorax. If you want to exclude pneumothorax, if you want to exclude something else, that's okay. Let me tell. Okay, now you're talking. I like that. So tamponade, will it appear on CT scan or not?
Yeah, it need a CT angio.
Well, I don't think it will appear on CT scan. I think I need ultrasound.
That's good. So
I think I need ultrasound. Oh, echo.
Now you're talking. Now you're talking, guys. So CT scan, CT angio, all CT scan are angio. If you would doing in your hospital CT scan without contrast for trauma, it's useless. Not just useless, it's trash. It's not absolutely useless. So all trauma CT scan are with contrast. So this is number one. Number two, tamponade will not appear on the CT scan because it's very low amount. In trauma, you need only 100 to 150 ml of blood to start tamponading the right heart. So it will not appear in the CT scan. And you need, as you said, guys, you need an ultrasound or you need an echo. We do that in the ER. So that is excellent thinking and excellent. So what else? Type, guys. Nobody thought. Please, go ahead.
I'd repeat the brain CT because of the lucid interval for an extradural hematoma.
No, it will appear in the first CT scan. You don't need to repeat it unless there is any abnormality. If he tells you that there is a contusion, there is a small epidural, it will appear. Otherwise, even a very teeny tiny epidural, it will appear in a CT scan. Guys, CT scan is very, very sensitive. It's very good. It usually won't miss something unless, as I said, I already told you, a very teeny tiny spinal contusion, midbrain contusion maybe, but a big thing it won't miss. So I'll tell you how I approached it, and how I thought of it, and how I solved this issue. So first thing, when I came, I made sure whether the reading is correct or not. And you should do that, guys. This is the first step. You want to make sure this is a true reading, whether this blood pressure cuff is good or not. You want to make sure what happened during the transfer, the BP cuff got slipped. And if you adjust it well, and it will give you the right number. This is number one. Number two, I want to make sure that I repeat the number. I repeat the measurement. It might be correct. I have a fracture in the arm, and this will give you a false number. You will check the vascularity in the arm. Maybe you have a vascular, because the blood pressure cuff depends on the blood supply. And the CT scan you do for chest, neck, abdomen, and pelvis. You don't do for the arm. Sometimes it appears in the CT scan. It depends on the position, but most of the time we put the hands up. So the contrast we give through the arm. So if you have a fracture and you have an impaired perfusion to the arm, you will have an inaccurate blood pressure measurement. So you need to make sure that this number is really true or not. So I did that. It was good cuff, it was good size, and the arm was fine, and the perfusion was fine, and there was no fracture. We moved it to the other arm just to make sure the number was correct. It was 90/40. So next step. So the next step now this is a very important thing. It could be an advanced skill, but you need to know how to do fast scan or ultrasound for trauma. You all need to do that because the future is ultrasound. Now we have handheld ultrasound. I have it in my suitcase. I carry it all the time. I carry my own ultrasound connected to my phone. It's the future, guys. It's very expensive now, but in 5-10 years, it will be in everyone's pocket. So you need to learn how to do ultrasound. Ultrasound, you make sure that, of course, you'll tell me that we done CT scan. True, we've done it, but tamponade is not ruled out. Number two, the tube might have immigrated or displaced into the right bronchus, causing a right lung collapse. And this, maybe it was normal before the transfer, but when they transferred the patient from the CT scan, the endotracheal tube might got pushed to the right lung, and I've seen that it caused lung collapse. But the problem with this argument, the patient will be desaturating, not hypotensive. But still, you need to go with this patient, and I wish someone of you would said A, B, C. I wish one of you would said, I want to review the patient A, B, C, and start from the A, B, C, all above. That is the systematic way. You should go assess your airway, assess your tube, assess auscultate bilateral, make sure. You never know. And you go systematic and you go with the fast scan, make sure that the cardiac tamponade is ruled out. Do an X-ray. I don't mind. I did an X-ray just to make sure everything is fine. I made sure that the BP cup is fine. I modded the other limb, and still the patient was hypotensive. What I thought about, then I thought there is something wrong with the BP cup. I will put for him invasive arterial monitoring. I put for him an arterial line in the femoral artery, and I measured his invasive arterial. This is more accurate because non-invasive is not accurate. Still, he was hypotensive. Now, next step, what I thought of as two things. We thought of the patient had medication. He had drugs before the RTA, which is common. The patient had been taking any drugs that we don't know, either MDMA, either we have a lot of medication that can decrease the blood pressure, and it might affect your blood pressure later on. And this could be it. The patient intoxicated. Other thing is anaphylaxis from the contrast. It's been reported, and we have seen it. Anaphylaxis from the CT contrast, it can cause this blood pressure, low blood pressure, especially it happened after the CT scan. So what we did, we give the patient norepinephrine, we give him adrenaline, very low dose, and we put for him arterial monitor, and we sent for him tox screen. Tox screen came back negative, and it actually came back that the patient had an anaphylaxis from the contrast. So this is a nice case because it teaches you how to approach this patient from an ABC point of view. It keeps the basics on your mind. The possibility of having a neurogenic shock is still possibility. The possibility of having midbrain contusion is possibility. We did for him MRI later on. It was normal. The patient was extubated and was sent home after a few days. He had a minor contusion that did not appear on the CT scan, and he was fine. So I will skip it for the sake of time. This is the dynamics of shock. This is when you read shock in the books, you get all of the books give you this table. The hypovolemic shock is very low preload, pulmonary cardiac wedge pressure, cardiac output is high, systemic vascular resistance is high, all that's arrows up and down. The problem is, if I can measure the systemic vascular resistance on the bedside, shock will not be a major problem. You cannot measure systemic vascular resistance, you cannot measure the cardiac output, you cannot measure those. So you have to depend on others. These kind of tables are useless in the bedside, while it's very useful for the exams purposes. I'll skip this. It's a very interesting case, but I'll skip it for the sake of time. This is a video about using ultrasound. I'll show it to you because I think it's very nice. It will take only 2 minutes. This is how you use ultrasound to differentiate shock patients.
In this video, we will provide a brief overview of the RUSH protocol. This protocol uses diagnostic ultrasound to rapidly assess a patient who presents with the clinical diagnosis of shock. The evaluation components are divided into 3 main groups of elements. They are pump, tank, and pipes. It is important to assess the left ventricular contractility to determine the amount of fluid the patient's heart can tolerate during resuscitation. Additionally, poor left ventricular systolic function could very well be the cause of shock. The heart should be evaluated for other common causes of shock, such as cardiac tamponade, pericardial effusion, or pulmonary embolism that may make the pump work inefficiently. In In patients who present with shock, it is crucial to know their volume status, as well as responsiveness of the inferior vena cava to respiratory excursion. Bedside evaluation of the patient's IVC has been proven to be an effective method of assessing intravascular volume status, and also helps determine an approximate range of the patient's central venous pressure. A patient with a dilated, non-responsive IVC is unlikely to benefit from fluid therapy. Ultrasound examination of the abdomen and pelvis can also detect areas of free fluid or blood loss into the peritoneal cavity or other body cavity.
So I'll skip it for the sake of time. As you can see, ultrasound is the future. You really need to know and to develop your ultrasound skills. If you have an ultrasound machine, when I was a resident, we had this huge ultrasound machine, very huge. It's like weighs like maybe 500 kg, and nobody used to know the value of ultrasound. We would call radiologists for everything, and I was carrying that ultrasound. I would put it on the patient. It's very harmless. It's very available, and you can still do it and repeat it on the patient for tens of times, and you can do it on yourself, and you can repeat on your colleagues, and there are multiple courses that can teach you ultrasound, and it's very, very useful, and I cannot stress this any further. Third case and final case, 70-year-old female, diabetic, hypertensive, massive upper GI bleed. This is a real case as well. Given 5 units of packed RPCs, taken by gastroenterology to endoscopy. The first part of the duodenum had an ulcer pulsating artery. It was clipped. Patient dropped hemoglobin from 11 to 4.8 after the endoscopy within 4 hours. Patient was in the room. I'm sure you're all familiar with these kind of cases. 3 times large melena with a blood pressure 8/50, heart rate 145. Gastro called you on-call surgeon. What is your next step? Okay, guys, quickly, please. Someone volunteer. I still have 7 minutes. Okay, no volunteers. So then definitely the issue is, would you control the bleeding first, or would you resuscitate first? What is your strategy? Would you give the patient blood, FFP, and platelets, and how would you give it? And would you take the patient immediately to OR, and then you open the patient and you resuscitate, or what would you do? In this situation, we would definitely resuscitate first. It's not a trauma bleeding. The trauma you would control, then resuscitate. These kind of patients different, and then these are patients you resuscitate, then you control, because these patients cannot handle the trauma patient cannot handle waiting in the ER. You have to take them to OR immediately. But these patients can wait, and they are under monitoring for the last couple of hours, so you can resuscitate first. Whether you intubate or not, that's a different issue. How would you resuscitate? You would give the 1:1 ratio, meaning you give 1 unit packed cells, 1 unit FFP, 1 unit platelets. Meaning, if the patient hemoglobin is 4, you need to give them 5 or 6 units of packed cells. So give them 6 units FFP and 6 units platelets. Or if you don't have platelets in your blood bank, which is very common because platelets half-life is very low, and you would give 1 to 2 to 2. So you give 6 units blood, 3 units of FFP, and if you don't have platelets at all, then that's what you got. If you have cryoprecipitate, if you have TXA and factor 7, you can do that, of course. That's very nice. Hemorrhagic shock, there isn't much thing to say. In practicality, what you do in hemorrhagic shock is you only control the bleeding, and there isn't much you can do. You resuscitate 1:1:1. There is a lot of data and scientific and theoretical knowledge where they want to give PCC, you want to give whole blood, you want to give calcium, hypotension. All these are theories, all these are studies, but in real life, nothing matters like surgical control of bleeding. You resuscitate 1:1:1. You take the patient, you stop the bleeding. Otherwise, patient will be lost. Using whole blood is definitely is a very attractive option. Has been used in the U.S. military very often since the Afghanistan war, and they call it the walking blood banks, where the whole blood is being transfused instead of fragmented the blood into packed cells, FFPs, and platelets. And this is another topic on its own. If you give massive transfusion, meaning if you give more than 4 units within the first 2 to 3 hours, then you have to give calcium. Calcium is very important. It's cheap, it's available. Please give calcium. If you give more than 4 units, please give 1 ampule of calcium, calcium gluconate, calcium carbonate, whatever you have, just give. Massive transfusion protocol, it's a very important protocol that you have in every major hospital where your blood bank knows what's going on. Unfortunately, if you have a shortage in blood products, it's very difficult to apply the massive transfusion protocol. But if you become in an authority position or administrative position, please consider applying a mass transfusion protocol. Hypotensive resuscitation, this is mainly in trauma, where you allow the blood pressure to be low while you take the patient to OR before you control the bleeding. And this is studied in penetrating traumas. We have something called TEG, which is thromboelastography. This is a video of it. It shows the bleeding the coagulation capability. It's a study that is being used mainly by cardiac surgeon. We trauma surgeon came behind and we adopted this technology, and it shows you the strength of the clot, whether you need to give TXA, whether you want to give cryo, whether you want to give platelets, or which part of the coagulation process is impaired. So it will guide your transfusion. As I told you, hemorrhagic shock has a lot of theoretical knowledge and theoretical questions, but in reality, nothing exceeds the surgical or interventional in that case, or the endoscopic bleeding control. I conclude. This is about the Rabawa. I will skip it for the sake of time, and I'm done. And thank you so much. I hope I didn't take too much time. I'm happy to receive any questions.
Anybody who's like to ask, just unmute yourself. Nothing in the chat. Actually, it was very comprehensive.
Wow.
I guess anybody who want to ask.
That's not a good sign, Dr. I'm sorry. I
used to say it is either you understand everything or you didn't understand anything when they don't ask.
I think it's the latter one. That's the honest.
No. Actually, it was very comprehensive. I think.
I'm sorry. I speak very fast, and because of the time, I know it's a bit late, unfortunately.
I think Dr. Mamoun have a question.
Okay, proceed, Dr. Mamoun, please.
Hi, good evening, everyone.
Good evening.
Good evening.
Hi. My name is Mamoun Nabre. I'm a trauma critical care surgeon in consultant in Khubar University, Imam Abdurrahman University. Been there for the last 5 years. I just admire your presentation, especially the introduction to this new critical care and trauma specialty. I did my fellowship in US in Miami, Ryder Trauma Center. So I'm practicing here in Dammam, and I went last year to Sudan. I went gave a lecture about trauma, but we will contribute more and help all the new generation will benefit from this experience around. And your talk was very, very, very interesting, and admire it. And especially the introduction to these new guys, new fresh bloods, to know about this subspecialty and how it works out. And it needs a lot of funding, a lot of resources, and a lot of powers. So thank you very much for educating our young colleague, and I will happy to be participating in the futures about any other activities. Thank you very much. Appreciate it.
Thank
Dr.
you.
Mamoun, please send us your phone number so we can communicate for further lecture, inshallah.
Okay, no problem.
Since nobody had further comment or question, I would like to thank Dr. Shaher for his kind participation in our Sudanese Surgical Club, and we hope to communicate, or he's going to participate in the future, inshallah. Thank you very much.
My pleasure. Thank you for the invitation. I'm honored, and I hope all the best. Thank you, Dr. Reem, for the invitation and for moderation.
Thank you.
Thank you very much, Dr. Shaher. Appreciate it.
My pleasure.
Thank you so much for the wonderful presentation. God bless you.
Thank you for listening. Thank you.